Good evening, everyone. I think we'll get started. People are just continuing to flow in. Um, but welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LIUNA, the Laborers International Union of North America. I'm Leslie Rattan and very happy to be moderating our webinar series. If you've been with us before, you know that we run every other Tuesday evening from 6 to 7. And just as a reminder, all of our webinars are archived. They're recorded and archived, and you can find them on the Canadian Concussion Center website. So if there are any that you've missed or you want to go back and rewatch anything, you can find them there. Before proceeding any further, we'd like to acknowledge the Indigenous peoples of all the lands that we are on today. Even as we meet virtually, it's important to recognize the lands we each call home and reaffirm our commitment to improving relationships and understanding with local Indigenous peoples. From coast to coast, we honor the ancestral and unceded territories to the Inuit, Métis, and First Nations people who call this land home. So back to the concussion webinar series, just for those of you that may be new, each session focuses on a different aspect of concussion, and we generally have an expert speaker that's with us presenting for about the first half, and then the second half is followed by a question and answer segment. So if you have any questions for our speaker tonight, I would ask that you look to the bottom of your screen and you'll see that there's a Q&A icon. You can just click on that and enter any questions that you have, and those will be answered later. If you're having any technical difficulties, please enter those into the chat, and Christian will get back to you. He has also just posted the link in the chat, so you can go to that to find all of our previously recorded sessions. Before we go any further, we're just going to run a very quick poll, and we do this every session just to get a sense of who is in the audience to help guide us in terms of our future planning. I'm just going to take a look and respond. So I'm really pleased this evening to welcome back Dr. Abe Snaiderman, who's going to be presenting anxiety, depression, and PTSD before and after concussion. Dr. Snaiderman is an associate professor in both the Department of Psychiatry and the Department of Medicine at the University of Toronto, and he's the founding director of the Neuropsychiatry Clinic at the University Health Network, Toronto Rehabilitation Institute, the Brain and Spinal Cord Program, where he's worked for almost 30 years. He's been involved in the field of physical and neurologic trauma for many years. As a clinician teacher, he's been involved in training medical students, residents, fellows, and ancillary health professionals, as well as the general public for over 25 years. He's a member of the exam board and examiner in psychiatry for the Royal College of Physicians and Surgeons of Canada. He is the winner of the Ivan Silver Award for Excellence in Mental Health Education, given by the University of Toronto. He is the vice chair of the board of directors of Community Head Injury Services and a member of several advisory boards for guidelines in acquired brain injury and stroke, and other organizations, initiatives, and programs. In his spare time, he plays guitar, much to the dismay of his family and neighbors. And with that, I'm going to turn it over to Dr. Snaiderman.
Thank you, Dr. Rutan, for the kind introduction. As always, it is my pleasure of presenting today, and let's start sharing this thing. Okay, can everybody see well? And can you see my cursor, my pointer?
Yes, looks great.
Perfect. Okay, so I'm just going to get rid of this. Give me a second. There. Okay. So we're going to be talking today about anxiety, post-traumatic stress disorder, and depression in concussion. And it is important that we talk about these topics as they are extremely common in people that have been through a concussion. So the university asks us to disclose any conflict of interest, and as such, I can disclose that for this conversation, this presentation, I have no conflict of interest. I am not affiliated with industry of any kind. I am a clinician teacher, not a researcher. Hence, no research was harmed in the making of this presentation. I am going to be quoting research by people who are way smarter than I am. And I have 30 minutes, which is not enough time, but anyway, what are we going to do? I asked AI, one of the new AIs, to produce a slide that shows the left creative brain and the left logical brain and the right creative brain. And AI did a fabulous job in showing us the logical aspect of the brain and the creative. But AI kind of screwed up because he reversed the order. So this is the left hemisphere, this is the right hemisphere, should be the other way around. So my job is still safe for the time being. But for the purpose of this presentation, I am going to assume that all of us agree that the brain is the organ, the mind is the software, and brain and mind are exactly the same thing. Brain is the hardware, mind is the software. When our brain gets injured, our mind gets injured. When our mind is not working well, chances are our brain is having problems. So concussion is a brain injury, and the caption says, well, we'll know more once we do an MRI, but yes, this could be a career-ending injury. I wish we had MRIs in every single contact sport place. We're not there yet, but I'm sure we will at some point. And speaking of brain injury, this is the most famous brain injured patient survivor in the history of neuropsychiatry. This well-dressed, gentle person is Phineas Gage. And this is 1848, shortly after he had a terrible accident. He's holding in his hand what's called a tampering rod. This was used when laying railroad track, and indeed he was a railroad track worker. His job was to tamp the dynamite cartridges so that the crew can then blow sides of the mountain or blow terrain to lay the tracks. Unfortunately, as he was tamping the dynamite, there was an explosion and the rod entered his right cheek and exited through the top of his head. You can see that he lost his eye and there's some sort of deformity. Now, why is this so important, so interesting? 20 years later, when he consulted with Dr. J. M. Harlow, he described him as the following: October 20th, not so far back, 1868. He made the following description. I'm going to spare you the trouble of reading such a difficult text. He described Gage as indulging at times in the grossest profanity. I love their language back then. He was impatient, obstinate, capricious, vacillating, and I love this one, a child in his intellectual capacity and manifestations, but with the animal passions of a strong man. To the point in which his friends stated that he was no longer Gage. This is a very famous phrase in neuropsychology and neuropsychiatry because it is the first time that a human survived a catastrophic brain injury, did not only not die, but went on to function organically well, but intellectually suffer a complete change in personality. So it's the first time we were able to document brain injury as a cause for mental health changes. Very, very quickly, we can divide the brain in anatomy and in function. So I'm going to use both. So if we go from the bottom of the brain, your nose will be here, your ear will be here, the back of your head is here. So if we start looking at the brain from the very, very bottom, we see this as a primitive area of the brain. Primitive both in terms of evolution. This is what we call the basic survival brain, the reptilian part of our brains. Reptiles have this and a little bit of the other brain, and that's it. But this is where all the automatic pilot of our body is. The breathing, the heart beating, temperature control associated with further up, hypothalamus, crying, sleep, etc. So this is a very primitive area. If we go further up, we go from the survival brain to the emotional brain. So this is what mammals have. We have the limbic system in green. So this is an area that is responsible to producing the emotional responses. A reptile might have responses that are reflexes in they look emotional, but not very sophisticated, while my dog will have fantastic emotional display. You know when a cat is happy, you know when a dog is happy, and more certainly, you know when a human is happy or angry or terrified or just scared. And we move forward up, and then we go to what's called the neocortex. Neo means new, and it's not that it's new in the brain, it's new in the evolution scale of the animal kingdom. Obviously, this developed millions of years ago, but it's still the neurocortex. And this is what makes us human, the blue areas. This is what basically makes us be creative and organized and learn very complex structures and very complex materials and relate and form the world as it is. Although if you look down south, you still have questions as to whether all of us have the neo thinking, the neocortex, but that's another topic for another very controversial and long presentation. So moving on, how common a problem is it to have psychiatric sequela? Sequela just means the residuals of an injury after traumatic brain injury. This is a very highly quoted research by Richard Bryant from 2010. And this is what they studied. So they studied 12 months after a brain injury, a very large cohort of patients. About a third of the patients reported a psychiatric disorder after a brain injury, 1 year after a brain injury. That is huge. Now, interestingly, 22% develop a psychiatric disorder that they never had before. So one thing is to have had a history of anxiety, and then you get a concussion or a more severe brain injury, and sure enough, your anxiety flares. But it's interesting that almost a quarter develop a new psychiatric problem. What are the most common psychiatric disorders? Not surprising, about 9% depression, generalized anxiety, another 9%. So between depression and anxiety, 18%, 20%. Post-traumatic stress, and we'll talk later about it, about 6%. And agoraphobia, 6%. Agoraphobia is the type of phobia where people are afraid of leaving their homes. They're afraid that if they leave their homes, they're going to have horrible anxiety and something catastrophic is going to happen. How does a brain injury affect the mental health? It's a very interesting question. Now, I am not an engineer, but Carlos Obreja in 2000 devised, who is an engineer, devised this equation, C equals E over R multiplied by 0.5. I'm not sure I understand it, but it makes me look smart. I actually do understand a little bit. This is only applicable in low or medium energy impacts to the head, assuming that the skull does not break, and it tells us about what happens to the vibration in the skull after a hit. So let's look at it. C equals the wave propagation velocity, how fast the wave after the hit travels to the brain. E, the resilience of the tissue inside the brain, how much the tissue can resist that forces. And the density, how dense that tissue is. And this is crucial because the brain has fat and has blood and it has gases in it, oxygen dissolved in the blood. And it has very strong bones and tissue and muscles in the skull. So it's a lot of density. So what happens? So this is your nose, this is your ear over here, the back of your head. So let's imagine that you suffer a hit and you hit your head right here. And so if you see those black lines in the periphery and you think of the skull as a concave surface that is transmitting the energy downstream from the neocortex, and then you see the second line, the energy, the waves, almost like a tsunami. And as the energy starts traveling down, because of the shape of the skull, the energy gets maximized, concentrated, what we call collimated. at the center of the brain. So what sounded like a trivial impact, by the time those concussive waves reaches the center of the brain, they have amplified. Why is this important? Because in the reptilian brain and in the limbic system is where all of these neuron clusters live. And these are very important clusters of neurons. Neurons are the cells in our brain. We call them monoaminergic nuclei. Nuclei is the plural of nucleus. So these nuclei are the ones that produce a whole bunch of substances called neurotransmitters. For example, orexin, dopamine. You've heard perhaps about Parkinson's disease and dopamine, noradrenaline, GABA, histamine. Antihistamines blocked by blocking this neurotransmitter. And serotonin. Many of us have heard about serotonin, which is one of the mood regulating substances in our body. So what happens is that these factories of neurotransmitters, these nuclei, send information, send all of their manufactured substances through what we call pontine, the pons, basal cortical relays. So this is the 401, the highways that transmit all of these substances to the rest of the brain. The problem is that if you have, and if I go back, an injury right there where the energy concentrated, you're going to have problems with destruction of these factories, of these nuclei, and disruption of these railway tracks or electric cables, if you wish, that transmit those substances to the rest of the body. And those are critical in maintaining mood and other functions. So let's talk about mood syndromes in brain injury. What are the features associated with depression? Now, we've all felt helpless at some points, especially when we're a kid, but in depression, that's a very common feeling. A sense of deep, deep guilt, unjustifiably most of the time, shame. People feel embarrassed when they're depressed, lonely for sure, pain. This is relatively new. Over the past 20 years, we've come to discover that pain is a symptom of depression. It could be headaches, could be muscle aches, but it is a symptom of depression. What else is also associated with depression? Feelings of hopelessness, and we'll talk about this in a few minutes. Isolation, and what is also associated with depression, especially here in Toronto, is a certain hockey team's lack of championship wins. I'm not going to say which team it is, but the fan says I cry at night. So this is the DSM-4. DSM is the Diagnostic Statistical Manual of the American Psychiatric Association. And this is the criteria by which we mental health professionals diagnose depression. Now, I'm going to make it easier for you. And instead of going through the whole criteria, we're going to simplify it. So number one, you have to have depressed mood or loss of interest or pleasure in daily activities for more than 2 weeks. Anybody can have a bad couple of weeks and doesn't mean you're depressed. The next point is absolutely crucial. Impaired function, social, occupational, educational, familial. If you're not impaired functionally, you don't have a psychiatric illness. You might have depressive symptoms, but you don't suffer from major depression. If you are impaired functionally, then you have an illness. And that applies basically to every single disease in humans and in animals. You might have, after a certain age, aches and pains, and that doesn't mean you have arthritis. Or you might have a touch of arthritis, but it doesn't mean you're dysfunctional. It's when you're dysfunctional, when you're not functioning the way you were at baseline, that's considered an illness. And you need to have, for depression, 5 of the 9. Depressed mood or irritability, decreased interest or pursuit of pleasurable activities, weight changes, 5% either up or down, insomnia, poor sleep, or hypersomnia, excessive sleep, psychomotor agitation or retardation. That means when somebody's agitated psychomotorly, it's not just that your thoughts are going really, really fast, that you're moving fast, you're fidgety, you're going back and forth, you can't sit still. And psychological retardation is when you feel you're thinking and walking through molasses. It's hard to think, it's hard to concentrate. Next comes fatigue, very common, and feelings of worthlessness, excessive or inappropriate guilt, as we talked about, diminished ability to think or concentrate, and more importantly and crucially, thoughts of death or suicide or even a suicide plan. There's very sophisticated research going on demonstrating that suicidal thoughts are actually a brain chemical issue. It's going to become a very interesting topic. Now, I'm going to make it even more easier to remember. So a major depressive disorder has emotional symptoms like we talked about, constant sadness almost every day, feeling of worthlessness or excessive or inappropriate guilt, suicidal thoughts, intent or actions, loss of interest or pleasure in favorite activities. So those are the emotional ones. We now go to the physical ones. Loss of energy or low energy, psychomotor impairment, as we talked about, both thinking and moving, aches and pains, no sleep or too much sleep, changes in weight, low to absent sex drive, and change in appetite. Oftentimes, not oftentimes, always, I ask my patients when I assess them the first time about their sex drive, and some of them are kind of embarrassing. What am I talking about? And you have to think that appetite, sleep, sex drive, energy are all very primitive reptilian brain functions, way down to the base of the brain. So I ask about it because that's a very good example of how the rest of the brain is functioning. And then we go to behavioral symptoms, either restlessness or apathy, no interest in doing anything, or irritability, impatience, and aggression. Now, I have been doing this for a long, long, long time, and I am convinced that women have a much better brain than we guys do because they have the capacity to say, I'm sad or I'm angry. We guys, and I'm generalizing, I know, we guys go, or we get impatient, or we throw things, or we leave me alone, that kind of thing. And that also is a behavioral symptom of depression, but we should learn through educating our kids better that it is okay to cry and it is okay to say you're sad. It doesn't make you weak. And then lastly, the cognitive symptoms in difficulty making decisions or focusing, problems with attention, memory problems, slow thinking process. Now, what are depressive disorders? There are many depressive disorders, as you see. Each circle represents one. In our case of concussion, in this talk, we will call it depressive disorder due to a medical condition. In this case, the medical condition would be a head injury, a brain injury, a concussion, could be diabetes, could be something else. But what all of them share is sadness, guilt, shame, irritability, and suicidality. Excuse me a second. Now, what about depressive disorders after traumatic brain injury? The frequency, according to many studies, goes from 6% to 77%. And you're going to say, Snaiderman, wait a minute. How can one study say 6% and another study says 77%? What the hell? What's going on? Either make up your mind. The problem is that in the many, many studies about this particular topic, the populations used to study are heterogeneous. That means different from each other. So one thing is to study somebody at age 87 with a head injury and compare that to a teenager that suffers a head injury in hockey at age 17. Very different population, very different man from a woman, very different somebody with lots of medical illnesses or somebody very healthy. Another problem is that there are many ways of measuring depression, and there are many, many scales, paper scales. So you don't really know whether you're measuring depression as a symptom or depression as an illness, because it can be both. You can feel depressed and yet not have an illness called depression. You can be depressed. Let's hope we're not depressed tomorrow morning, but you can be depressed about something that happened, and in 3-4 days, you're feeling better. And also arbitrary cutoffs in depression scales. What is depression? How many symptoms you need? What we do know is that first year post-traumatic brain injury depression ranges from between a quarter of people to half of the patients suffering from traumatic brain injury, which is a lot. How common? The epidemiology of depressive disorder after TBI. What about the effect of personal history? So let's try to dissect a little bit more who are the people who get this depression. So we know that having a history of mood and anxiety prior to having a head injury predisposes you to have a head injury. And having previous poor social functioning in general, whether it's school, friends, family, also has an increased association of depression after a brain injury. The effect of the different risk factors is not the same at the beginning of the injury than a year later. So psychosocial factors might be more relevant in the later stage of a brain injury. So at the beginning, when somebody is injured, I call it early arrivals, late departures. When somebody has an illness, particularly in this case, a brain injury, everybody goes in to see the person injured and tries to help and sends texts and phone calls and visits, etc. And as time goes by, the patient might not be progressing as rapidly as one would like, and all those social contacts start petering out. So that is important, psychosocial factors at the chronic stages. What we do know very clearly is that alcohol abuse, and I might say alcohol use in general, after a brain injury, is a risk factor for depression. Now, how do we compare the regular garden variety depression versus depression after brain injury? Both are very similar in presentation, but there are some differences. In traumatic brain injury related depression, somatic symptoms, somatic means body, fatigue, pain, sleep, might be related to the sequelae of the brain injury or non-brain physical trauma. So say you're driving a car and somebody rear ends you and you have horrible neck pain and back pain and your head hit the steering wheel and now you broke your nose and you cannot breathe. So all of those symptoms might not be related to depression, might be related to brain injury, but you have to differentiate them. Cognitive symptoms, how you think, might be related to the brain injury and not depression. So you have to keep that in mind. Irritability, poor frustration tolerance, and apathy are common after a brain injury, not necessarily to depression. And insight deficit. Insight is the capacity to self-monitor, to say, yeah, you know what, I'm not doing well. Or yeah, I think I have depression. That's called insight. As opposed to, no, I'm perfectly fine. I'm fine, which is lack of insight. Of all the slides I'm going to show you, and I don't want to go too late, but of all the slides I'm going to show you, this is the saddest one. This is Statistic Canada, the latest available data as of the census of 2012 to 2016. This is the number of homicides in Canada in 2012, 13, 14, 15, and 16. So they are all around, let's say, 500-ish, 450. So there are almost 400 killings in Canada every year. Each one of those is a tragedy. But what keeps me up at night and what makes me very sad about this statistic is that suicide happen 10 times more and accidents happen 30 times more, disabling accidents as a cause of death, and we don't hear about it. You hear about homicides everywhere in CP24, or as I call it, constant panic 24, all the time. We don't hear about suicides. 10 times more suicides a year. It's tragic, and yet we don't hear about it. What are the rates and predictions of suicidal ideation during the first year after brain injury? In this study by Michael Prang, 25% of patients after a head injury, mild to severe, between 2001 and 2005, almost 600 people, a quarter had suicidal ideation. What are the predictors? Prior suicide attempts. So if you have a history of having attempted suicide, that's a high risk. History of bipolar disorder or depression, less than high school education, which means less resources, less capacity to cope perhaps. And the rates of suicide ideation about TBI patients exceeded those found among the general population, sometimes by 3 times. So it's something that we need to monitor for.
Okay, Peter, I think you know what this chat's about. Well, this is never easy, is it? You've been struggling over the past few months. You've let the team down. I mean, surely you must know what they think of you. You're not coping. Say, look, I'm sorry, but it's not working. You see, the bottom line is, you're just not good enough. You are a failure. Just because you have a young family, that's no reason to keep you on. I mean, quite frankly, Peter, you'd think a grown man could look after you.
Pete, hi, sorry about the last minute catch up. So there's this job I want your input on. It's very similar to the one we have just completed, but the timelines are much tighter.
Is it you or anxiety talking?
I love the Aussie accent. This is a fantastic campaign in Australia about what anxiety does to our thoughts. So this poor guy just having a self-conversation was sent to see the manager and he thinks he's going to be fired, and all that we call catastrophic thinking. So when that type of thinking is widespread, we start thinking about anxiety disorders. There are more than 7, but let's say 7 anxiety disorders: generalized anxiety disorder, panic disorder, agoraphobia, which I mentioned before, post-traumatic stress disorder, PTSD, social anxiety disorder, social phobia, simple phobia, which is the most common. Virtually all of us have sort of phobia, and OCD, obsessive compulsive disorder. In the interest of time, I'm going to be talking only about generalized anxiety disorder, GAD, and PTSD. Let's talk about GAD, generalized anxiety disorder. This is the type of illness that people who are constant worry wards suffer from. Excessive anxiety and worry occurring more days than not. And again, function has to be affected. Quality of life has to be affected. At least 6 months in duration. The anxiety has to be about a number of events or activity, not just one thing. It's difficult to control the worry. The patient tells us, I can't shut my mind off, I can't stop worrying. And it has at least 3 associated physical symptoms. The cognitive symptoms, what do people with generalized anxiety disorder think? Something is going to go wrong, very common. This worry is going to make me nuts. Maybe they don't say make me nuts, but they recognize, they have insight, this is not normal. I need to be sure nothing bad is going to happen. So issues of control. What are the physical symptoms? Muscle tension, pain, abdominal headaches, neck pain, feeling keyed up, feeling on edge, restless, angry, irritable, and definitely not sleeping well, waking up in the middle of the night and start ruminating, thinking and thinking and thinking. What are the behavioral symptoms? Avoidance. Like me tonight, avoiding the news or newspapers, restricting involvement in activities due to excessive worries about what could happen. And the typical is, what if? What if I walk down the street and I get hit by a car? And what if my kid gets hit by a bicycle? And what if? And it's incessant. And one scenario is proven wrong. Okay, so my kid got home safe, but what if then we run out of electricity, and what if, etc. So it's basically unstoppable. Excessive reassurance seeking or over preparing for something perceived as dangerous, like some presenters might do on a Tuesday for an audience of 60 something people. I don't know. Now, generalized anxiety disorder. The most effective form of treatment is by far cognitive behavioral therapy. And we're going to be calling it CBT. We don't have time for me to tell you what exactly CBT is like. I will deal with it in a few minutes, but I will give you recommendations on how to look for it. Exercise, meditation, And a combination of CBT and medication in very difficult to treat cases is the best approach. There are different types of cognitive behavioral therapy and many types of therapy. But in this particular study in traumatic brain injury, motivational interviewing, very much to what I'm doing right now, informing you what traumatic brain injury is and what anxiety is after brain injury is very helpful, as well as cognitive behavioral therapy, which combine both motivational interviewing and CBT, have better outcomes. Okay, we're not going to deal with this right now. Let's move on to the next topic. The cartoon says, and the caption says, and for the rest of his life, the young reptile suffered deep emotional scars. Obviously, we're talking about trauma. So trauma can be defined in many ways, but let's talk about what happens after a trauma occurs, like post-traumatic stress disorder. In order for somebody to be diagnosed with post-traumatic stress disorder, first of all, you have to have a traumatic event, like really. Of course, you have to have a traumatic event, but the controversy is what for me is a traumatic event, for somebody else might not be traumatic, and vice versa. So it is difficult to ascertain where the cutoff is. There are many cultural differences too. Now, in order to have post-traumatic stress disorder, you need to remember the traumatic event, so you need recall. In order to have PTSD, you need to have reliving experiences of the traumatic event, such as nightmares, flashbacks in which the person all of a sudden feels he or she is, or they, I have to get used to that. They are literally back at the scene where the trauma occurred, and they have intrusive thoughts. So that's a reliving component. So trauma, recall, reliving, avoidance of the traumatic situation or circumstances surrounding the event. So somebody who was rear-ended in a car might have a terrible fear of driving again and avoid driving. Heightened arousal. What does that mean? Feeling keyed up, tense, easily startled all the time. The slightest noise creates adrenaline response. It has negative effect on mood and thinking, attentional and memory issues, and as expected, all the reptilian brain functions like appetite, energy, and sex drive. It is difficult to differentiate, I'm conscious of the time, difficult to differentiate between post-concussive syndrome with headaches, sensitivity to light, memory deficit, and dizziness, and PTSD with re-experiencing symptoms, shame, and guilt, because they share all of these features in this Venn diagram: depression, insomnia, irritability, trouble concentrating, fatigue. So sometimes when somebody sends me a patient and they present with these features, I have to really work hard at teasing out which is post-concussive syndrome and which is PTSD. There is overlap of symptoms, and they share basically the same brain mechanism. I'm conscious of the time, so I'm going to be moving a bit faster. The treatment is through psychological approaches, cognitive behavioral therapy, neurorehabilitation. If the person has a substance use problem like alcohol, which is not uncommon in post-traumatic stress, people resort to non-pharmaceutical anxiolytic, anxiety decreasing medications or substances like cannabis and alcohol, and end up even being more depression, more anxious. So what happened after a brain injury? It's one brain in 10 people. Depression and anxiety are very common. There's oftentimes caregiver burnout. The patient himself or themselves feel a sense of burden. Access to care is difficult, and these are complex cases with social, financial issues, and also oftentimes legal under themes. So let's say somebody has a brain injury, they develop headache, dizziness, fatigue, which produce fear and anxiety, which causes heightened perception because now I'm frightened, so all of the symptoms I have in my body are amplified, which creates anxiety and catastrophic thinking, which lowers my mood, which increases headaches and dizziness and fatigue, which makes me feel anxious. This is called a feedback loop. So that is what happens in mild brain injury and post-concussive syndrome. What are the treatments? I strongly recommend this book. I get no financial reward from anybody for this book, unfortunately, because it's been a huge, huge, huge bestseller. It's called Mind Over Mood. Highly recommended, available everywhere. Cognitive behavioral therapy is the base of the book, can be done individual. Social network structure, consistency, and empathy are crucial in the treatment of these people. I named my dog 5 miles, so I can tell people I walk 5 miles every day. And by that, I mean exercise. Gradual start, as tolerated, and I can tell you is crucial, highly effective, underprescribed, underused. Frequency is more important than type or duration of exercise. The goal is, after a gradual increase, 5 times 30, 5 days a week for 30 minutes. That's it. Your heart rate has to be increased with your breathing rate increase. And there are plenty of excellent beginner videos on YouTube. Take home message: mind is brain, mental health is brain health. Psychiatric disorders are very common after brain injury. Depression is the most common, followed by anxiety, but both coexist. Physical and cognitive symptoms after a brain injury might be related to depression and or anxiety. Physical symptoms can precipitate mental health problems and vice versa. And depression and anxiety disorders are highly treatable. But one has to remember that, like anything in life, attitude is everything. Just tell it to me straight, Doc. Can I still run this weekend? And with that, I thank you for your attention. So I'm going to stop sharing. I'm sorry if I went over time. Okay, Leslie, take it in.
Okay, thank you so much. That was fantastic. So just to everyone out there, if you have any questions for Dr. Snaiderman, this is your chance to get them answered. Okay, and just enter them into the Q&A box. So we have a question: where does one seek or receive neuro rehab? Which medical professional or paramedical pro?
Okay, good question. And oftentimes, I call our institute, Toronto Rehabilitation Institute, as the best kept secret on University Avenue. The best approach is to, first of all, talk to your family doctor or nurse practitioner. Get a referral to a rehabilitation specialist. There are many in the city, many in the province. Short of that, your family doctor can refer to either psychiatrist, psychologist, psychiatric nurse, mental health nurse, social worker, any mental health care professional to get screened and to get assessed. But for consistent neuro rehab, you need to access one of the tertiary centers like Toronto Rehab, West Park, which is now part of UHN, Bridgepoint, etc.
Great, thank you very much. We have a couple of comments about how fabulous your presentation was.
Oh, stop it.
Fiona is asking, this is a great question: can you comment further on the impact of cannabis on anxiety?
Excellent question. For the past 5 years since it got legalized, there's always questions about cannabis and anxiety. This is the thing. And one problem with me is that I start talking, I cannot stop, but we'll try to make it concise. There are 130 plus compounds in the cannabis plant. We know 2. We know very well 2 of them. We don't know what the other 128 plus compounds do. What we do know is that cannabis decreases anxiety in the short term, but brings up depression in the long term. Cannabis affects cognition both in the short term and in the long term. So think of the typical cartoon of a quote unquote stoner, sitting in a basement eating pizza, playing video games, doing nothing. And it's not that it's just doing it because he wants to. It's literally effects of cannabis on the areas of the brain that motivate, pays attention, encode memory. The manager of the brain, so to speak, tells you what to do, what not to do, when to do it, and not to do it. We used to think that cannabis was not addictive. And that was in the 70s and 80s when the variety of cannabis was very mild. The later forms of cannabis is way stronger. So we're seeing a lot of problems with cannabis and people functioning. I guarantee in the next 5 years, there's going to be a huge number of studies showing that the problems with cannabis already starting to get published, but with small numbers. So I never prescribe cannabis in people with a brain injury, ever. The only time I don't prescribe it, first of all, the only time I would refer somebody to be prescribed cannabis is in palliative care. Somebody who has an intractable disorder or is dying. And at that point, we really don't care about cognition.
Wow. Okay. Thank you. Christy is asking, is medication as effective for treating depression when someone has PCS as it is for someone with non-concussion?
100%, but we have to be careful. We have to start the medication at a much lower dose and ramp up slowly, because the brain was impacted and is tender, and we have to be careful. I'm always mindful of, all of you know about perhaps the placebo effect, when you think something's going to happen and then you take the medication, and sure enough, if you think the medication is going to help you, it helps. If you think the medication is not going to help you, it might not help. The nocebo effect is when you are absolutely certain you're going to get side effects, you're going to get side effects. So I tell the patients, please don't Google stuff. Trust me a bit. I'm not going to prescribe you something that's going to kill you. Trust me a bit. Don't read the stuff. These are medications that have been around for 40 plus years, millions of doses all over the world, safer than Advil, safer than naproxen, safer than aspirin, safer than insulin, and all the medications we just take and don't think about it. So yes, the treatment is very effective. The thing is that it takes 4 to 6 weeks to start working. So my patients tell me, thank you, Dr. Snaiderman, you gave me side effects and I don't see crap about the benefits. So you have to wait it out.
Okay. Next question, sort of similar. So does management with medication change for depression and anxiety when it comes to patients with and without brain injury? And do they typically stay on these medications long term?
Okay, good question. A major depressive episode left on its own what we call the natural history. If the patient survives, and 11% of people with major depression kill themselves. So let's assume the patient is one of the 80 plus that make it. A typical depressive episode lasts 18 months on average. The medication takes 4 weeks to start working. Another 4 weeks for us to find the right dose. So that's about 2 to 3 months. If we only use it for 6 months and then we stop it, the depression might not yet be fully treated. So we typically say anywhere between 1.5 to 2 years after a concussion, you should be on an antidepressant if you have symptoms of anxiety and depression. And it works the same for anxiety. It's the same response for anxiety. These are medications that go, I'm not going to bombard you with data, but to the emotional areas of the brain and the neocortex, the new areas of the brain. And those are very similar circuitry. So it works for both.
Okay, that's great. Thank you. There is such a stigma about mental health, and it's not something I want on my medical record. Is there any way to avoid being labeled?
It is very interesting how some people would say, I don't mind if you put in my in my medical records that I caught syphilis or that I have hemorrhoids, but don't say that I'm depressed. Mental health, brain health, Stigma kills. There are ways to document, and I understand why many of us are reluctant to have our file say depression or anxiety or PTSD because it makes us look like defective. Well, you are defective. You have an illness. It's a brain illness. It's depression and anxiety. There's nothing to be ashamed. Stigma is what has been killing thousands and thousands of Canadians through suicide. And I showed you the slide. Stigma kills. There's nothing to be embarrassed. It is very interesting that Gen Zers, the younger generation, they don't give a crap, excuse my language, about stigma. They are way more open to, yeah, I'm taking an antidepressant, or yeah, I'm depressed, I'm seeing a psychologist, and it's going well at all. Because we've been making, as professionals, a much, I like to think, better job at publicizing this is normal, this is health. It also helps that some media, some celebrities or influencers, now they called, have been very open about their mental health issues. So it's like the song says, you have to kick at the darkness until it bleeds daylight. Bruce Coburn. Love that song.
Mm-hmm. Great, thank you. Are you saying that if two people hit their heads and one person had depression prior to the accident, they're more likely to have a concussion or brain injury?
Let me clarify that.
I think probably meaning, yeah, are they more likely to have persisting symptoms?
If somebody is depressed and then has a concussion, they're more likely to have persistent symptoms of concussion, yes.
Can you recommend something for people with resistant depressive disorder? After trying for many years, I feel like I'm a really extremely tough case. I exercise and I do as much as I can, but just feel like I can't be rewired anymore.
Well, I don't know how old you are, but you might be of a certain age that you saw One Flew Over the Cuckoo's Nest. If you saw the movie, ignore it. If you saw the movie and you saw the scene with electroconvulsive therapy, you're going to think that I am crazy recommending it. Now, the way electroconvulsive therapy, electroshock, is portrayed in the movie made a huge disservice to mental health for decades. Michael Douglas was the producer, the Michael Douglas, and I still haven't forgiven him. The way ECT is done is under general anesthesia, safer than childbirth. The mortality of ECT is less than many procedures that are done all over the place without people even thinking. If it was me and I had treatment-resistant depression and I tried 5 or more antidepressants unsuccessfully, and I tried CBT, and I'm exercising my butt off, and I'm still feeling depressed, the safest, safer than any antidepressant, safer and more effective than any other intervention, in this case would be electroconvulsive therapy. Every single hospital in Ontario offers it. It's 8 to 12 treatments every other day. You go into the hospital, you come out the same day. It is the most effective antidepressant we've known. There are newer forms of what we call neurostimulation, neuromodulation, like TMS, which is transcranial magnetic stimulation. Also effective, less clear data when it comes to traumatic brain injury. ECT, traumatic brain injury, is not a contraindication for, concussion is not a contraindication for ECT. You can have it. If it was me, if you were my relative, I would be begging you, please forget about the stigma. Please get 8 to 12 treatments of ECT. That's my point.
Okay,
I'm slightly
great.
passionate about it.
Yeah, thank you. We have a number, there's a few questions just asking about resources. One about neuro rehab in Edmonton or Alberta. Yeah, I'm not sure. There's also a question about Toronto. Just FYI, I had actually done the talk 2 weeks ago, and my presentation should be posted. I'm not sure if it's there yet, but it will be. And at the end of my presentation, I have about 4 or 5 pages of different types of mental health resources if you're interested. So, okay, I'm just conscious of the time. When you have depression linked to TBI and get treatment for it, would you expect recurrence of depression later in life or being more susceptible to it?
Well, we have a very sophisticated audience. This is
Good
a very good
question.
question. And it's nuanced. So I'm going to try to be nuanced myself, something that not always happens. If you have a history of depression and then you get a concussion, you already have a major depressive disorder. So major depressive disorder tends to be relapsing, tends to return over certain stages of life, depending on many things. You're not absolutely guaranteed to get depressed, but if you have a loss in the family or some other catastrophe or some problem, then you're more prone to getting depressed. That's without the concussion. If you then have a concussion and then you get depressed again, you could be more prone to depressions anyway. Doesn't mean you cannot be treated. And those are the cases in which we recommend long-term use of treatment, whether it's depression or therapy, and consistent exercise. Yes.
Okay, excellent. Is there any research on mental health impacts in people with repeat cases of concussion? Is there a higher incidence?
Let me see if I understand the question well.
I think if someone's had repeated concussions, is it likely that their mental health issues
Yes.
are going to be worse?
Yes. Now, again, and I might get in trouble with this, but I don't care. There's concussions and then there's concussion. You can get a mild concussion or you can get what we call a complicated concussion. Just like any other illness or any other symptom, you can have a fever of 37.8 or 41 in the centigrade scale. So it all depends. The more serious concussions you get, like football players, hockey players, definitely boxers, and don't get me started about boxers or WWF and all that nonsense, with which the whole goal of the sport is to give somebody a brain injury. That's a knockout. It's a brain injury. Don't get me started. So yes, severe concussion after severe concussion after severe concussion, you're guaranteed to have mental health problems.
Okay, thank you.
Not necessarily in mild concussion.
Okay. What do you recommend for someone with a brain injury who has perhaps tried to overdose on antidepressants and other medications and is still struggling with depression, but their healthcare providers are refusing to prescribe any new medication?
Change healthcare provider? I mean, there's no reason why.
Yeah.
Overdoses happen. People, we are mental health care providers, Dr. Tan and I, but unfortunately we don't read minds. And when somebody really, really wants to kill themselves, nobody stops them. So there's no reason to say, I'm not going to prescribe something new because you overdosed on this other antidepressant. It's like saying, yeah, you know what, you failed the chemotherapy, you're stage 1 breast cancer, but you failed chemo, I'm not going to try you in another one. What kind of nonsense is that?
Yeah.
So definitely, if somebody has overdose of an antidepressant, they need to, first of all, need to be in the emergency department and maybe in hospital to see what's going on and to clear the overdose, and then to establish what's going on and to remain safe, but definitely.
Absolutely. Okay. Okay, I'm going to just get one more in. If I'm taking an SSRI for anxiety before the concussion and remain on that SSRI after my injury, does that make my concussion recovery longer?
Actually, that's we have a sophisticated audience
Yeah.
tonight. There is actual research in the stroke, not brain injury, but bear with me, in the stroke population, in which people after a stroke are given an antidepressant, even if they are not depressed, because there are animal studies that showed that people, brains on antidepressants, who then sustain a neurological trauma, whether it's a stroke or a brain injury, do better, recover faster than the ones that are not on it. So if you were lucky to be on an antidepressant and then you have a brain injury, your chances are actually better. Does that mean that we should all start popping up antidepressants just in case? Absolutely not. But what it does mean is that we're starting to understand that these agents are more than antidepressants. Just like now, Ozempic is a drug for everything, we're starting to understand that antidepressants are actually neurogenic. They help new cells to form in the brains, and they also help. I hate to use plasticity these days because everything is neuroplasticity, but it helps the reconnection of circuitry in the brain. The studies are in animals. There's early studies in humans, but everything in my practice over that many years has shown me that the people with brain injuries that we put on antidepressants did better afterwards than the ones that didn't. And it's still
Right.
early in the research, but that's a very good question.
That's a fantastic question. I think we will have to end on that one. Thank you so much. I'm sorry I couldn't get to everyone's questions. Just as we always do, you're going to be getting a very short survey. We really welcome your feedback, suggestions. Also, if you didn't get a question answered, you can always put it into the survey. I always just remind people, please put your email address in there as well, because they are anonymous. We don't know who is asking the question. So please watch out for that. And I would just like to take this opportunity to thank Dr. Snaiderman for all of your time and excellent presentation, and for the Q&A. He's actually going to be back with us again in 2 weeks. So another mental health talk. He's going to be talking about drugs for neuropsychiatric symptoms of concussion at that time. So hopefully we will see you back.
So if you're a glutton for punishment, join again.
That's right. No.
Please fill your evaluations. We presenters live and die by your feedback. We cannot get better if we don't get your feedback. You can be brutal. There's one question that says, I'm afraid antidepressants will affect cognition and memory. No, you won't. They actually help.
Okay. Thank you so much. Have a great
Thank you,
evening,
Dr.
everyone.
Rutan.
And
thank you, everybody. And thank you, Christian, for all the tech help. You get unrecognized oftentimes, but without Christian Pedersen, this couldn't happen.
That's right. Yeah. Thanks so much. Have a good night.